But it's a pleasure to start off the JAM year with our HIV presentation or update with one that we have to have for our license renewal in a couple of years. So we might as well get it accomplished. And next month we're going to have one of our other ones. We'll talk about that at the end. But this is my I do not have any financial relationships with the commercial entities to disclose. So I'll go ahead and get started where this is our HIV update for HIV diagnosis, prevention, and care. So the objectives tonight is to give a brief overview of CDC's Ending the HIV Epidemic, its latest prevention plan. Also a review of the recent advancements in antiretroviral therapy in the US. And lastly, a review of the current HIV diagnostic algorithm, anticipated changes, and the potential impact on the HIV diagnosis and linkage to care. I'm having to keep clicking this thing out. Okay, I got it. I thought we need to probably put this in right away because there'd be some questions about the relationship of HIV and COVID-19. And this is some information that's pretty relevant. They keep it updated. CDC, this last update was like July 28th. But based on limited data, let me move one other thing here. Limited data and people living with HIV who are on effective HIV treatment have the same risk of COVID-19 as people who do not have HIV. But of course, those that are having problems with low CD4 counts and maybe not on effective highly active antiretroviral therapy, they may have a greater risk of contracting or having at least some significant illness or maybe even less significant illness to COV-2 infection. As of July 7th, there was no reports of manufacturing concerns for supplies of antiretroviral therapy or Truvada and Descovy, the two PrEP antiretrovirals. So we're in good shape there. Matt, how do you think I can get rid of this right here?
I think that's just...
Oh, it's just there?
Yeah.
Okay.
You might be able to move it if you want.
Let me just try moving one. Yeah, I got it. All right, thank you. So I wanted to also share a little bit about HIV incidence, a little different perspective instead of just a US or Florida, but look at it as a regional perspective. And this little map in the upper right-hand corner is CDC's idea of how to regionalize the US. So you can see the South is a pretty extensive stretch up the East Coast, and the Northeast is small and the others. But from 2014 to 18, HIV diagnosis in the US decreased 7% among adults and adolescents. But the annual diagnosis varied among some groups. The MSM population, men who had sex with men, went down that 7%. They matched that. But the IV drug use overall was up 9%. However, if you start looking at some of the regionalization concept, almost 38,000 of the new HIV diagnoses in the US and dependent areas in 2018, 51% of them were in the South, according to that, the way they rank the Southern district. And if you look at it, the actual numbers, you can see that there was over 19,000 in the South. These are incident cases for 2018. And compared to the other three areas, they were all, less than 10,000 cases each. But another interesting way to look at it is the way they break down in the way of urban, suburban, and rural areas. So you can see, as you would expect, the urban areas were had the most of the percentage. But in the Midwest and the South, the suburban and the rural areas had significant more of the incidence cases than the other two regions. And clearly the South, due to its population, would contribute more to that 51% than the Midwest would have. And Florida was pretty much a representative of what you would expect in that southern region, even though for the last 10 years, we've seen a decrease of about 5% in newly diagnosed cases based on year of diagnosis from 2009 to 18. However, if you look at from 2013 to 18, we were on a pretty steady increase. Florida's HIV rate was 22.7, and we're only behind Georgia and Louisiana have higher rates. And actually, all three of us are less than what the District of Columbia has for their rate. However, a little bit of good news there is that today, actually, the 2019 numbers came out for Florida incidents, and we were down by 4% from 2018, which is a good sign. So if you look at why CDC is their reasoning for this regional concept is the South's larger and more geographically dispersed population of people living with HIV creates a challenge for prevention and treatment. And one could understand that, you know, with the more rural areas and having to have resources to reach both urban and rural. But by our numbers that came out today for Florida, it looks like things are trending maybe in a more positive path. So CDC's initiative is End the HIV Epidemic. Plan for America actually started February of 19, but funding was awarded earlier this year, I do believe. Of course, everything got sort of covered up with COVID, but many of the sites that I'll be showing soon will have already received their funding or will receive their funding for the 2020 and onward. So the goal of the EHE is to reach a 75% reduction in new HIV infections by 2025 and at least 90% reduction by 2030. So this is based on the 27 incidence rate of 37,000 new cases a year. And to show you how aggressive this is, if you look at 75% reduction from that 37,000, I mean, that's going to drop it down from about 37,000 to about 9,000 cases by 2025. So that's a pretty aggressive a goal that they're trying to put forth. There's 4 areas that that the plan actually focuses on, is to diagnose all people as early as possible after the infection, to treat the infection rapidly and effectively to achieve sustained viral suppression, which is still measured at less than 200 RNA copies, and to prevent new transmissions, including PrEP and syringe service programs. And then last but not least is to respond quickly to potential HIV outbreaks and to get needed prevention and treatment services to people who need them. I have to laugh a little bit, Matt and I, we have something flying around in here and he's trying to kill it. So you see a little movement. So another unique approach is this is not a coast-to-coast nationwide type of effort. This is a focus resources on areas where HIV transmission is most frequent. And again, based on those 2017 data. So this ends up being about more than 50% of the new diagnoses occur in 48 counties throughout the country, Washington, D.C., San Juan, Puerto Rico, and 7 states where greater than 10% of the cases are in rural areas. And if you look at the map, it's the shaded pale green states where they may not have a county that had the predominant number of incidence cases where that county would have been picked instead of the whole state. So the whole state was collected again, maybe because of the rural effect of it. You'll have more rural areas and they can broaden their their efforts in those areas. If you're interested in Florida, it's 7 counties listed there on the right that were included into the EHE grant. So if we look at all 4 of those areas just a little bit deeper, in diagnostics, some of the recommendations are to use state-of-the-art testing technology, and I think we're really moving toward that now. Most of the screening that is done is with antigen antibody testing. There's the new algorithm that came out in 2014, so that's already being looked at as pretty commonplace now, and we're already looking at changes, and we'll talk about that later. Make HIV testing routine in healthcare and non-healthcare settings. I think we're moving toward that pretty briskly. Encourage people who are at substantial risk for HIV to get tested for HIV at least annually. That's been in previous recommendations, prevention programs. But one new thing that I think is of interest, and we're already seeing sort of a proving ground for this with the how we're handling COVID testing and getting the results and the message out, is to identify and implement innovative technologies and programs such as consumer-controlled testing strategies. And I'll go a little bit more into that. And this tends to be one of 2 pathways. You have a direct access testing, where it's entirely consumer controlled, minimum to no healthcare provider involvement. The test kits are obtained online, pharmacy, or some Department of Health. See, Florida is participating in this, where they actually, through the DOH website, you can go through and request a HIV self-test. I'll give you some more information on that. And it's sent out to the person's home free of charge. So what may be optional is the consumer would have to seek medical advice, counseling, and linkage to care on their own, and it's usually by phone for most cases. The other option is healthcare provider mediated testing, where there's usually consultations with the provider prior to testing. Could be in person, but lately, because of the COVID, a lot of it's through telemedicine. The provider submits a test order at a local lab and sends the consumer a self-collection kit for use. The consumer returns the sample to the lab. Results are relayed to the consumer, usually by an online portal, and the consultation and linkage to care is primarily based on those results. So the self-testing, you can accomplish this by either self-testing or mail-in self-testing. So self-testing is directly related to that direct access, where it's performed at home or in a private location. And this could even be a private part of a county health department. It's rapid-based in this case. And the only FDA-approved rapid HIV self-test is the OraQuick Advance, which is an HIV 1-2 antibody test. It's not the most preferred test for this type of scenario, but it's the only one that's FDA approved. Even in the package insert, if you read it, the OraQuick Advance is recommended not for use until it's after 60 days of the risk factor. So it is useful in looking for like an established infection, not that helpful for like an acute or early. As I mentioned, Florida DOH is now participating in sending out kits for self-testing, this exact kit. It started late 2019, but numbers very small. But as of this year, it's again was fairly small, the number of requests that came in through the website. But as more self-quarantining was being encouraged in the state as well as the nation, you can see the request rapidly increased for these. This is 844 in July, individual kits, not individuals, but individual kits. And it is a single use kit, but that's not also documenting how many were actually used in follow-up testing that we heard from. The other is mail-in self-testing, which includes a specimen collection kit for a dry blood spot that is obtained at home. The kits can be ordered online or by the user or the healthcare provider. Again, you send it to the lab for testing. The results are provided by an online portal in most cases, and follow-up would be probably the same way. Only one FDA-approved dry blood spot test, which is just a IgG EIA antibody test, which is lab-based. However, there are several laboratories that have validated antigen antibody tests for dry blood spots and could be used for this purpose. But at this point, this is the only FDA approved that we have for like a mail-in self-test. Okay, the next area, let me block something out here, is treatment. So newly HIV diagnosed persons are quickly linked to care, and HIV treatment starts as soon as possible after the diagnosis. So this is commonly known as test and treat programs, and we'll have a little bit more information next couple of slides on that. But what we're looking at with this advanced focus on treatment, what used to be done in 60 days and then was moved to 30 days, now we're actually looking at having to train providers, counselors, linkage coordinators to really do this in a very short time period, as like a 7 to 10 days, to the point that we even have linkage to care coordinators to help make sure that all of these steps that I'll show you in a few minutes are accomplished within the desired time frame. But also a focus is to identify and follow up with persons who have stopped receiving HIV care and treatment and attempt to re-engage them. So these are three focal points of the treatment component. So if you look at the test and treat, this is out of our Florida Department of Health manual protocol, and others around the country are using something very similar. Some may be doing this over a period of 7 to 10 days. Others may be trying to consolidate this even tighter to like a day or 2 days. But for this presentation, like on day one, you would want to take a new HIV diagnosis. So this could be somebody with an acute infection where they're HIV antibody negative, RNA positive, or an early infection where they're HIV antibody positive and had a negative within 6 months prior to that, or even a chronic infection, somebody that's been antibody positive more than 6 months, has been off therapy but now returning to care. They would all qualify for this entry into test to treat. So that assessment is done, and actually they can start ART on this first day. Some jurisdictions will prescribe 30 days of medications. Others will maybe prescribe just a week's worth. But and also a lot of jurisdictions are just taking a rapid positive, and in the areas that they're at, if they feel like that rapid positive is sufficient to consider putting them in test to treat, that is allowed as well, because within days they would be doing a follow-up testing where they'd be doing the medical and psychosocial evaluations, eligibility assessments, and they would draw bloods for baseline viral loads, genotypes, and maybe even confirmation if a rapid test was done on the previous day. So there's more counseling, and then there will be linkage to a primary care on follow-up. So the third component is usually about a week later. where the clinician can review the baseline labs. They can check with the patient to see how the medications are doing, if they have any side effects, and then they can adjust the antiretroviral therapy, or they can let that 30-day script run out and then readjust then, especially if there's any signs of any mutations from the genotype. And then eventually they'll go out of the linkage, the test and treat model, and they'll go to a long-term primary HIV care program. So these are the first-line international guidance on the first-line antiretroviral therapies. As you can see, in days of past, we had many, many drugs to choose from, but as time has moved on, we've been able to really consolidate some of the choices that are working the best. And if you look at the IAS-USAs, we basically have 3 regimens that are used in most cases. Biktarvy, which you hear a lot advertised on TV, Triumec, and the combination of Tivicay and Descovy. So these, the next slide will give you a little bit more about how successful they're doing. If you look at the first 48 weeks of some of these trials, a number of trials that are provided here, you'll see that more than 50% have an integrase strand transfer inhibitor as maybe the anchor. So all of these regimens that are orange are really anchored by an integrase inhibitor. So that is becoming to be the primary path that a lot of the regimens are taking is, and if you'll see the success rate that when the viral load is less than 50 copies, they all have a fairly high percentage of success, up in the upper 80s, 90 percentiles. But there's others that are also anchored by either protease inhibitors or even some reverse transcriptase, and all have some relatively good success rates at 48 weeks. So we're doing a lot better with the therapy portion. And I think I have one other slide. And so the question is, why are so many of these include INSTI, the INSTI inhibitors? And if you look at monotherapy, just the percent decline in logs of HIV RNA in a monotherapy, and we know in the US, the monotherapy is not really a desired path, and it's not even approved. But if you look at the performance of it in such situations, you can see the integrase inhibitors have anywhere from a slightly less than a 2 log reduction to almost a 2.5 log reduction, showing the differences to the other RTIs, the protease, and even the entry inhibitors. They're all showing a good reduction, but the integrase seems to be the predominant, and no wonder why they're an anchor in most of the regimens. So prevention, increase the availability of pre-exposure prophylaxis. An estimated 1.2 million Americans can benefit from PrEP, according to the latest December MMWR in 2019. And the other component of prevention is to promote syringe service programs to reduce HIV risk, provide entry point services to reduce overdose deaths and other infectious diseases. We could do a whole talk on the impact of this on both HCV and HIV, and how it relates to the opioid epidemic. So more than 2,500, approximately 7% of the new HIV infections occur each year, of that 37,000 that we talked about earlier, from people who inject drugs. So pre-exposure prophylaxis, commonly known as PrEP, is available for people without HIV, but who are at risk of being exposed to HIV through sexual contact or indirect drug use. There's 2 medications now that have been approved for use as PrEP by the FDA. Each consists of 2 RTI drug combinations in a single oral tablet taken daily. That's Truvada or Descovy. Either one of them can be used. There's some supporting evidence of their performance. These are just 2 of the more recent ones, but there's a lot in literature. You can look at how over the years how they've been investigating PrEP as a prophylaxis, and how many times should you take it, what dose should you take. But these 2 I thought were as interesting as when taking PrEP. This is from Marcus and others in 2017. When taking PrEP daily and consistently, and here it actually says, or at least 4 times per week, the risk of acquiring HIV is reduced 99% among MSM, but it's highly dependent on the PrEP adherence. Where another study by Martin et al. Was when PrEP is taken consistently, the risk of acquiring HIV reduced by 74 to 84% among people who inject drugs. So different success rates with different modes of transmitting HIV, of acquiring HIV. Again, this latter study was based on tenofovir, and I'm not sure if there's any more recent studies with like Descovy on if that improved that percentage. But condoms remain an important prevention strategy for STIs, including HIV, despite PrEP use. But if you pay attention to some of the billboards around town, and other areas, you can see that condoms, if they're mentioned at all, it's probably like just a reference on the bottom that it remains recommended as part of the prevention strategy. There's now some under investigation, some longer acting injectable PrEP medications, which are usually bi-monthly, conducted by the HIV Prevention Trials Network. Actually, there is a call tomorrow if anybody's interested. If you haven't received the link from the Southeast AETC, there is a 1:00 p.m. presentation on long-acting injectable PrEP medications. If you don't have the link, drop me an email and I'll be glad to send it to you, and you can register for the webinar even in the morning and still be able to log into it. What you don't see a lot on when you hear about PrEP, other than you hear about a lot about the once a day regimen, taking not even a regimen, either Truvada or Descovy. But what you don't hear a lot about is ongoing assessments for patients that are on PrEP. Every 3 months after PrEP initiation, an individual would have to test for HIV to make sure they're still negative, test for STIs, other STIs, test for pregnancy for the females, and then if their risk factor involves IVD use, to make sure that they're aware of the syringe service access. And then there's actually renal function testing performed at the first 3 months and 6 months thereafter. So it's not an easy process to stay on, which will actually, Oh, one other thing. As important it is to start PrEP, it's also important to know when to stop PrEP. It's when you're HIV positive, you need to discontinue taking the RTI antiretroviral and move to a more involved regimen, including probably protease or the INSTIs. Also, if there's any abnormal renal results, need to stop PrEP. Non-adherence would be an issue to stop. And if they're no longer at risk, of HIV, then it would be time to stop. So we talked about what they have to go through in the ongoing assessments, and this could be a reason why in this slide by CDC for in 2018 that the PrEP coverage, these are the percentage of people that were prescribed a PrEP divided by the estimated number of persons who had an indication for it. And if you see the total, it's quite low, only 18%. So that's a long ways from that CDC recommendation that 1.2 million people could benefit from PrEP. That 18% is a fairly small number. And in addition, you can see quite a bit of ethnicity disparity between the PrEP use. And the goal for EHE, I don't know if this is the 2025 or 2030 goal, it's probably the 2030 goal, is to increase PrEP coverage to those that could benefit from it to 50%, which may be a lofty goal looking at what we see so far. But for Florida, there was an estimated 115,000 plus HIV negative persons that were deemed at risk, and only 6.6 were prescribed PrEP. 6.6% were prescribed PrEP in Florida. So in 2017. So our numbers were even lower at that year, and they may be higher now, but we're lower than the percentage from CDC's. Let me see here. The last category of those four focus points were enhanced surveillance activities to identify where HIV prevention and treatment are most urgently needed. We were used to partner notification services or partner referral services, so that will continue. But what's new is to identify HIV genetic clusters and subsequent transmission clusters. We hope to have more about that in a later JAM presentation later in the year. But this is compliments of Dr. Spencer and Dr. Rawlinson about using how Florida perceives using our genetic cluster testing is that a person is diagnosed with HIV and a provider will order a genotype test as well as viral load and perhaps a CD4. The genotype sequence is reported to the health department as well as to the and through the provider to the patient. The genotype sequences are compared as well as partners notification services are conducted equally. And then on the surveillance side, what you would see is the genotype comparison would be hopefully identify some HIV transmission patterns. The partner notification, there would be notification of sex and needle sharing partners, of their HIV risk to a key individual, and they would be offered HIV testing and treatment. What also probably could be moved over here is if this was a test and treat program, you would also see offering a medication very early at the diagnosis as well for the key individual or the key individuals. So now I wanted to move into some of our testing updates. The CDC and APHL, they've all been pushing for over the last few years to eliminate the generation language for how tests are compared to each other because of some of the manufacturers maybe taking it onto themselves of calling their new products a 5th generation or 6th generation and not really showing an improvement in sensitivity and specificity. It was decided upon or encouraged that we look at these assays, not in generations, but in actually what they detect. So there's antibody-only assays, which includes the old 1st and 2nd IgG antibodies, as well as the 3rd generation IgG, IgM detection assays. There's antigen antibody assays, which are primarily probably the most prominent screening assays we have in the US now. Now they can be differentiating and non-differentiating, and we'll go over that in a few minutes. And then there's the nucleic acid test, which includes both qualitative and quantitative RNA detection. So this is the algorithm. I won't spend too much time on it. I think most everybody knows this 2014 HIV diagnostic algorithm pretty much by heart now. But you screen with an antigen antibody test. If it's positive, reflects to a supplemental. Sometimes it's referred to as a differentiation antibody immunoassay. And if there's discordance, you go to an RNA assay, primarily as your tiebreaker, but it also will help you discriminate the acute infections from the established. So the FDA-approved non-differentiating HIV 1/2 antigen antibody assays is, as it infers, it cannot really separate an antigen reaction from an antibody reaction to HIV-1, and it doesn't differentiate antibody reactions for HIV-2. And there's a number of manufacturers that most of us are familiar with, the Abbott, Advia, Roche, and Ortho, and they're all very similar in their throughput of the specimen, the kind of specimens they can handle, and their ability to multiplex. Most of these are like chemistry analyzers. The FDA-approved differentiating HIV 1/2 antigen antibody immunoassays, there's one lab-based, the Bioplex 2200 from Bio-Rad, and the Abbott used to be a Lyra determined combo rapid test. So both of these have the ability to differentiate, but not in the same way. The lab-based you can see the 5 different results that you can end up with a person that maybe is reactive on the Bioplex. In fact, it is sometimes so confusing that APHL recently, just July of 2020, released a report that you may want to obtain, and it helps in interpreting the results and the role of these multitude of results that you can end up with a Bioplex. You might find it very interesting and helpful in your result interpretations. But it does separate antibodies from the antigen, both antibodies 1 and 2, as well as P24 antigen for HIV-1, where compared to the determined rapid test, it only differentiates the antibodies for 1 and 2 together from the P24 antigen. And what I want to emphasize is neither one of these tests do not equate to a confirmatory testing scenario. They're both FDA approved for screening only. But the determined was released right about the time the 2014 guidelines were released. So they were not included in the original new diagnostic algorithm. The Bioplex had not even been close to being released at that time. But since then, the CDC released a technical bulletin in November 2017, basically saying that the determined can be used with serum and plasma as the initial screen in the diagnostic algorithm in smaller labs where instrumented antigen antibody tests may not be available. We still only have one FDA-approved confirmatory antibody assay, the Genius. Again, it's a non-subjective dual path platform rapid test. 2 analytes or antigen compounds for HIV-2, 1 and 2 there, GP36 and 140, and 4 antigenic proteins for HIV-1, and it's read non-subjective reader when interpreted by a proprietary software. The only thing I wanted to add to that is the interpretations that are now used with Genius is an assay protocol file of version 1.3 So hopefully everybody that is using Genius, please verify that your interpretational guidelines are 1.3, excuse me, and not 1.1 or 1.2. In the past versions, it gave the analyte results for HIV-1 and HIV-2, and that did cause some confusion. And it caused a lot of additional testing when maybe it was the analyte 1 was positive, but the HIV-2 analyte was indeterminate, and that happened quite often. And almost every one of those cases were an HIV-1 positive, and when you did RNA, the HIV-2 RNA was negative. So that and as well as some other issues led the manufacturer, the FDA, and APHL to recommend Genius to include an assay interpretation, which is really what is now being promoted. And you do see it's much more simplified. It may not even mention HIV-2 as in these cases when HIV-1 was positive. There are some HIV-2 indeterminate is a new result, and HIV indeterminate is a new result, and HIV-2 positivity with HIV-1 cross-reactivity is new, but and at least 2 of these 3 would require additional testing by HIV-1 NAT and perhaps HIV-2 NAT, depending on the NAT results. The third test of the algorithm is HIV-1 RNA testing, sometimes known as the tiebreaker assay. To aid in the diagnosis, it's a qualitative test by Hologic, the Aptima HIV qualitative. It's approved for use with plasma and serum, and the results are detected or not detected for RNA. However, this is one of the issues that is driving a lot of the work that I'm about to show you and suggested algorithm changes in the future, is that if we could move a test that has a dual claim, where an RNA test can provide both clinical management and diagnostics, it would be helpful in both getting people into care quicker, as well as there's HIV viral load tests are more common in many of the laboratories than this qualitative test. So it would make sense if we had a dual claim, we could be able to get testing done in perhaps a shorter turnaround time as well. We'll have more on this in a few minutes. Recent updates on some technology you may not have heard about. The Abbott Alinity's new platform for antigen antibody immunoassay testing was approved July of last year. The Alinity M RNA test for clinical management only was approved July of this year. Hologic Aptima HIV Quant, also it's clinical management test, it's viral load test. The latest revision was approved January of this year. Abbott will be discontinuing the HIV-1 VirusSeq, which is the only FDA-approved Sanger sequencing method in the US. That will come off the market December of next year, 2021. And there's Vela Diagnostics Sentosa SQ-HIV-1 next generation sequencing received FDA's de novo approval in November of last year. So these are just some of the more recent approvals and some market issues with some of those assays. So what are some potential changes to the 2014 HIV diagnostic algorithm? Here's some of the minor ones. We already talked about the new language, the new report scenarios that are accompanying with the Genius assay interpretations. So those are already incorporated and are accepted. The other potential changes are associated with bioplex users only. There could be a time when you'd have HIV-2 antibody positive, and the recommendation here is if you would still reflex to your differentiation test. And in this case, where HIV-2 is negative, you may want to consider going to an HIV-2 RNA testing to further rule out that HIV-2 antibody result. Another one that has not been approved but is being looked at is considered basically a fast track for the HIV-1 antigen result for the bioplex. Could you just go directly to HIV RNA testing? And again, there's insufficient data to recommend that at this time. Even though it's too many, it makes it absolute common sense to do and bypass some of the differentiation testing. But if that turns out to be negative, you probably would backtrack and do the differentiation testing as well. So these are some of the minor ones that are being worked out. A more common one, which is a major revision of the algorithm, and I have to preface this that at this time, there's no laboratory evidence or the laboratory evidence is insufficient to support the algorithm revision. I will show you some evidence that does support it, but it's insufficient at this time. Is to move the RNA testing, preferably it would be one that has a dual intended use claim for clinical management and diagnosis to the second step, and to move the supplemental differentiation testing to the third. And that would seldom be used. If it's positive by the combo test, antigen antibody, you would move to RNA. If it's a quantitative amount, a quantitative value, even if it's less than the lower limit of quantitation, but higher than the limit of detection, it would be considered an RNA detected case. And you could report the quantitative value. So this clearly, in a case of an acute infection, you could pick up the antigen reactivity here with the first test. You go to RNA dual intended use claim, and as you get a quantitative value, you could also have a confirmed diagnosis, and the quantitative value would act as your clinical baseline. What would you do with any cases that were target not detected or cases that were below the limit of detection? You may want to consider going to a supplemental differentiation test because if it turns out to be HIV-1 antibody positive, you may be dealing with somebody that is on antiretrovirals, but for some reason not disclosing that information, or they could be a lead and controller. Some of the old studies with Western blot show that 3 to 5% of the Western blot positives were RNA elite controllers. In other words, they did not really demonstrate any viral load whatsoever. But also, if it's negative, you would may interpret that the initial screen was false positive. If it's HIV-2 positive down here, then you've been able to differentiate. You've been able to basically confirm that this was an HIV-2 case, and that is maybe the reasons your RNA were target not detected. So the potential change, there are potential benefits to this change. It provides rapid linkage to care and clinical baselines. It reduces the wait time for entry to test and treat programs. It enhances postnatal diagnosis cases. HIV viral load testing platforms are more common in a clinical setting, a lab setting, than the qualitative RNA and maybe even the Genius test. Data supports, I'll share you some of Masiatra and others' data supporting this antigen antibody RNA QT algorithm for acute and established infections, as long as they're antiretroviral naive. So this is some of their data on early stage infection before initiation of ART. As you can see, if you looked at what they're considering a 2-test algorithm, is the blue boxes. So a 3-test would be this bioplex, the Genius results, and then the Aptima results. So if you look at an acute infection where you will see like on a bioplex, antigen reactivity or early antibody reactivity or both, and the Genius really doesn't confirm antibody reactivity, either being negative or indeterminate. And then the RNA is positive, either by a qual test or by the investigators used a CE-approved quant diagnostic Panther product, Hologic product on Panther. You can see that you see good correlation where 2 samples for the qual were negative when they should have been reactive in this case, where the quant qual test, the quant for qual you could call it, picked up those 2 cases, but it did miss one other case. So still the 2-test algorithm comparison had about a 98.6% success rate. If you look at established infections, those where it's primarily antibody positive, and you're also antibody positive on the differentiation test, there was 2 samples that were missed both by the qual and the quant test. They were both recorded as below, these are target not detected, but they list them as non-reactive. So still the correlation was excellent at 99.3%. However, there are some barriers to this reversing the algorithm. It's all contingent on those quant RNA assays approval for dual intended use. And it's unclear which of those assays are that are back in front of the FDA for that kind of approval. And typically, NAT is more expensive than serology confirmatory assays. But I sort of preface that if the serology confirmatory assay, as in Genius, it may cost the laboratories the same or more as their viral load assay. Data does not support this rearranging of the algorithm for ART experienced persons. And sometimes this is known as proof of positivity. And I'll show you their data in the next slide. And this will eliminate the ability to discriminate an algorithm-defined acute case from an established case. But I'd have to ask, is it important anymore? In the past, it's been very important, and some clinicians really want to know if they're in the very, very early stage of infection and treat more aggressively. But as you saw in the back slides, with the test and treat being so aggressive, is it really important now to being able to discriminate an acute from an established or somebody re-engaging in test and treat program maybe? So this is that data showing that these are individuals that are they're positive, and this is testing after initiation of ART. So they're going to achieve viral suppression, hopefully quite rapidly. You can see that the antibody testing is still very positive. It is impacting the Genius testing to some degree, which we have seen that as well, that it can delay seroconversion. But you can see that both the Aptima and qual missed 10 cases, and in the case of this quant diagnostic assay, it actually had 9 of the cases were considered target not detected. So the correlation here, 87.7%, was probably not be justified in reversing the algorithm for those type of ART experienced individuals. Again, either qualitative or quant is not helpful really in these type of scenarios of doing proof of positivity. You really have to search out documentation as much as you can. So what's on the horizon is some rapid and simplified HIV-1 NAT systems that have that dual diagnostic and clinical management claims. So we know of both Hologic and Aptima with their newer platforms are looking at it. The Cephia gene expert is looking at it. And then one of the true rapid tests is made by a company called Diagnostics for the Real World. The SAMBA2, which I think SAMBA stands for Simple Amplification Based Assay. And the problem with this, it can use a whole blood. It is considered a point of care rapid use, is I'm sure the way the company would like to proceed, but their limit of detection is around 1,000 RNA copies, which would really never satisfy, I think, the US goal of always looking at less than 200 as being viral suppression. So they have some work to do. This is basically my next to last slide. And I just wanted to end with the HIV care continuum, both presented as CDC is, where they look at both diagnosed and undiagnosed HIV infections. So you see basically a viral suppression of about 56% of both diagnosed and undiagnosed in the country. Still needs some work on keeping people retained in care. And then Florida uses a different approach where they're mostly looking at the continuum based on only diagnosed cases. So you'll expect, as you expect to see, our numbers for viral suppression and retention and in care are higher. So I just want to caution you that when you look at these continuum of cares, you really need to look at how they're based on either diagnosed or both diagnosed and undiagnosed. The last thing I want to share with you before we open it up to some maybe questions is that some publications you might be interested. The middle publication is the 2014 CDC APHL guidelines for laboratory testing for the diagnosis of HIV infection. That's about the 60-something page one. If you're interested in something lighter, read. We have updated, APHL has updated this suggested reporting language for laboratory diagnostic testing several times. The latest is January 2019. You can get that through the APHL website. And I just mentioned this earlier. This is one that was just released. It's more of a bulletin from APHL, July 2020, health guidelines on interpreting bioplex results for their HIV combo assay, just newly released. So I think I would really encourage anybody using bioplex to get a copy of that. I think it'll give you, will help you out. So with that, there's some people I would like to acknowledge for their help in putting all these slides together. And thank you, and we'll open it to some questions.